Hello everyone. Welcome to another episode of MRCEM Syllabus Mastery Podcast. I'm your host Dr. Rahil. Today we are discussing a critical and potentially life-saving protocol used in emergency medicine, the Major Hemorrhage Protocol. I created this podcast in response to a special request from one of my subscribers. Let's start with a clinical scenario. Just imagine you are the doctor managing this patient. A 48-year-old male is brought to the emergency department after a motor vehicle collision. He sustained multiple injuries and was intubated pre-hospital due to low GCS. His blood pressure is 90 over 60 mm of mercury and heart rate 130 beats per minute. So how do you manage this patient? It's time to use the ABCDE approach. To save time, I will not delve further into the details of his assessment and will focus exclusively on the Major Hemorrhage Protocol. From the information given, it's clear that he is in hemorrhagic shock. This situation is critical. This is where the Major Hemorrhage Protocol or MHP comes into play. I will walk you through this protocol using a simple framework called the 7 T's. This will help you remember each key step in managing a major hemorrhage effectively. Let's dive in. The first T is triggering the protocol. Knowing when to activate major hemorrhage protocol is absolutely crucial. We should activate major hemorrhage protocol if a patient is actively bleeding, leading to a heart rate above 110 beats per minute, or systolic blood pressure below 90 mm of mercury, or if you can't feel a radial pulse. But what about those borderline cases where you're not entirely sure? If you're concerned about a significant bleeding but the criteria aren't crystal clear, it's always better to err on the side of caution. Reach out to the transfusion department and have them on standby for MHP. It's all about staying prepared and prioritizing patient safety. The next T is team activation. When a major hemorrhage occurs, time is of essence. In a major trauma scenario, all the relevant specialists are typically involved from the very beginning. However, in the medical cases, once the major hemorrhage protocol is activated, the critical care team and hematologists also become actively involved in the management. I'm sure you are eager to learn what the major hemorrhage protocol includes and what blood products are provided once it's activated. Don't worry, I've decided to cover all that essential information towards the end of the podcast, so stay tuned. Now that our team is in place, what comes next? The third T is testing. Once the team is activated and on the move, the next crucial step involves rapid testing to assess the patient's condition and guide treatment. Let's break down the key tests that are typically conducted. Full blood count gives information about hemoglobin and platelets. Coagulation profile, very relevant especially in patients with bleeding disorders or on anticoagulants. It also gives fibrinogen levels. Venous blood gas gives a lot of information including lactate levels, ionized calcium and acid-base abnormalities like acidosis, etc. and sample for cross-match. These tests provide a snapshot of patients' current health status and are crucial for tailoring immediate and effective treatment during a major hemorrhage. The next T in MHP is tranexamic acid administration. A critical component in the treatment of major hemorrhage is the timely administration of tranexamic acid or TXA. This medication plays a key role in stopping blood loss and improving survival rates. It's essential that tranexamic acid is administered within 3 hours of the injury. The earlier it's given, the more effective it can be in preventing excessive blood loss. The protocol involves an initial bolus of 1 gram of tranexamic acid followed by an infusion of another gram over the next 8 hours. TXA works by blocking the enzymes that break down blood clots, which is crucial in a situation where every second counts to prevent further hemorrhage and stabilize the patient. While highly effective, the timing and dosage of tranexamic acid must be carefully managed to ensure it provides the maximum benefit without causing complications. With our emergency test completed and tranexamic acid administered, what are the next steps in our protocol. Up next, we will explore ongoing monitoring and additional interventions necessary during a major hemorrhage. The next T is temperature, maintaining normal body temperature. In the midst of managing a major hemorrhage, maintaining the patient's normal body temperature is crucial. Hypothermia can occur during severe bleeding and can exacerbate bleeding, complicating the situation further. To prevent this, blood products should be administered through a warming device. These devices play a pivotal role by warming the blood to body's temperature before it's infused, helping to stabilize the patient's core temperature and enhance the effectiveness of the treatment. One of the key tools we use is the Belmont Rapid Infuser, an advanced device designed for rapid and safe warming and infusion of blood products during critical situations. The Belmont Rapid Infuser can deliver warmed blood at high speeds, which is particularly important in cases where rapid volume replacement is needed to save life. By maintaining normal body temperature, we reduce the risk of further complications such as coagulopathy, where the blood's ability to clot is impaired. The next T in the MHP protocol is treatment targets. Managing a major hemorrhage requires not only rapid action but also precise targets, especially when it comes to blood pressure. For patients experiencing penetrating or blunt trauma, maintaining a systolic blood pressure between 80 to 90 mm of mercury is crucial until bleeding is controlled. However, if the patient has a traumatic brain injury, the target shifts to a higher range to ensure adequate cerebral perfusion. Here we aim for a blood pressure greater than 110 mm of mercury. Hemoglobin levels should be between 80 to 100 grams per liter and even higher, at least 100 grams per liter if the patient is actively bleeding. Other critical markers include keeping the fibrinogen levels above 1.5 grams per liter, platelet counts over 100, and INR at or below 1.5. The other treatment targets are to maintain temperature above 36 degrees centigrade, maintain pH above 7.2 and lactate level less than 2, and ionized calcium level more than 1 millimole per liter, and potassium levels less than 5.5 millimole per liter. We have covered the essential steps and precise treatment targets in major hemorrhage management. Is the protocol that demands accuracy and swift action, but most importantly, it saves life. Now we will discuss what constitutes major hemorrhage protocol. It may vary from hospital to hospital. For example, in my current hospital, we keep O negative and O positive bloods in A&E department. So when we activate major hemorrhage protocol, we receive 4 units of fresh frozen plasma, whereas in my previous hospital, the first pack or pack 1 contained 4 units of RBCs and 4 units of fresh frozen plasma. Due to shortage of O negative blood, men of any age and women above the age of 55 can be given O positive blood. Just to summarize, pack 1 contains 4 units of RBCs and 4 units of fresh frozen plasma or FFP. In some hospital, the pack 1 may also contain 1 unit of platelets. Blood products should be administered in a 1:1 ratio. For instance, 4 units of red blood cells are given, 4 units of FFP should also be provided. However, this does not mean they need to be given alternately. If only red blood cells are available initially, you can start the transfusion while waiting for the fresh frozen plasma. The key is to ensure that 1:1 ratio is achieved overall as treatment progresses. Once the MHP pack 1 is given, patients should have repeat blood tests including full blood count, coagulation profile, and blood gas. It's important to remember that this is not a major transfusion protocol. It's merely a temporizing measure to stabilize the patient until definitive treatment can be provided, such as surgery or an interventional procedure to stop the bleeding. Pack 2 contains 4 units of RBCs and 4 units of FFP and 1 unit of platelets. And pack 3 onwards contains 4 units of RBCs, 4 units of FFP, 1 platelet, 1 unit of platelet, and 2 cryoprecipitate. Now we will move on to the final section of the podcast, termination. After the critical phase of managing a major hemorrhage, there comes a time to stand down and start the recovery process. Termination of the protocol is as crucial as its initiation and requires meticulous follow-up to ensure patient safety and resource management. Once the situation is under control, the physician in charge will declare the termination of the major hemorrhage protocol. This is referred to as stand down. It's crucial that this is communicated promptly to all involved, especially the blood transfusion department. All unused blood components and transport boxes must be returned to the laboratory as soon as possible. This helps to maintain the integrity of the blood supply and ensures that these vital resources are available for the next patient who might need them. Now, the recap of major hemorrhage protocol. Major hemorrhage protocol is a life-saving approach designed to manage patients with severe bleeding effectively. It begins with triggering the protocol based on the key clinical indicators such as the heart rate above 110 beats per minute, systolic blood pressure less than 90 mm of mercury, or absence of a radial pulse. Once activated, the protocol ensures rapid delivery of blood products in a 1:1 ratio of red blood cells to fresh frozen plasma. Though initial transfusions can begin with what's available, ensuring the ratio is balanced eventually. The goal of MHP is not definitive treatment but to stabilize the patient until the bleeding source can be controlled, such as in the operating theater or through interventional radiology. Timely activation, coordination with the transfusion team, and adherence to the protocol are critical for improving outcomes in these high-risk situations. Now we have covered the full scope of the major hemorrhage protocol from initial activation to careful termination. Each step is crucial, designed to save lives and improve outcomes in dire situations. As we close today's discussion on the major hemorrhage protocol, I hope you feel more informed and empowered. Every step you take to learn and understand these protocols can have a profound impact. Thank you for joining me today. Stay curious, stay prepared, and keep making a positive impact. Until next time, take care and keep learning. Goodbye.